So I'd like to welcome our beloved Sulfisar for this gathering. And we have Dr. Vijay Kumar, President IAP Kerala with us, who is very active and coordinating the activities all over Kerala. Welcome, Dr. Vijay Kumar. And I'd like to welcome Dr. Ajay, who is the Vibrant Secretary. Ajay എന്ന് പറയുമ്പോൾ വൈബ്രന്റ് എന്നും കൂടെ അറിയാതെ വന്നു. Ajay to this gathering. And I would like to welcome all Dr. Jayakrishnan, all who have gathered here to this program. I would like to invite Dr. Vijay Kumar to say a few words.
Respected President of IAP Calicut, Dr. Mohan Das, Secretary Dr. Ajay, State Secretary Dr. Johnny Sebastian, and the esteemed Chief Guest of the Day and the Speaker, our beloved teacher, the Doyen of Pediatric Cardiology, Sulfikar Sir, and moderator Dr. Baswaraj, and other senior faculty members. Dr. Ravi Sir is here, Dr. Hari is here, and all the senior faculty and my dear friends. Today, we are observing World Obesity Day. Obesity is a dreaded pandemic of this century. At least 10 to 15% of our preschool and school children are having overweight or obesity. And even though asymptomatic, it can lead to coronary vascular disease, hypertension, diabetes mellitus, non-alcoholic fatty liver, hyperlipidemia, and many more. To enlighten this, we have our beloved teacher and mentor, Sulfikar Sir, with us. I am sure that this will be a great learning experience for us. And I wish the program all success. Thank you. Jai Hind, Jai IAP. Thank you, Mohan.
Ravi, good evening.
Good evening, Ravi sir. So now, this talk is on obesity, regarding prevention of obesity. And to introduce the speaker, Sulfi sir, ഇതൊന്ന് മലയാളത്തിൽ പറയുന്നതായിരിക്കും നല്ലത്. സുൽഫി സാറിനെ പറ്റി നമുക്ക് വളരെ, ബിക്കോസ് സുൽഫി സാർ ഇസ് വെരി ക്ലോസ് ടു മീ. ഞങ്ങള് 93 തിരുവനന്തപുരത്ത് PGക്ക് ജോയിൻ ചെയ്ത സമയത്ത് ആണ് സുൽഫി സാറ് DM ഒക്കെ കഴിഞ്ഞ് വരുന്നത്. അപ്പോ ക്ലാസ് എടുക്കാനായിട്ട് ഭയങ്കര ഇൻട്രസ്റ്റ് ഉള്ള ഒരു സമയമായിരുന്നു സാറിന്. അത് തുടർന്നും അങ്ങനെ തന്നെയാണ്. അന്നത്തെ കാര്യം നമുക്ക് കൃത്യമായിട്ട് അറിയുന്നത്. അപ്പോൾ പീഡിയാട്രിക് കാർഡിയോളജി റെഗുലറായിട്ട് ക്ലാസ്സുകൾ, ECG ക്ലാസ്സും മറ്റ് ഡിഫറെന്റ് കാർഡിയ കണ്ടീഷൻസ്, അതുപോലെ ഇടയ്ക്ക് ഡ്യൂട്ടി ഉള്ള സമയത്തൊക്കെ സാറ് ചെറിയൊരു സ്ലിപ്പിൽ ചില പ്രോബ്ലംസ് ഒക്കെ എഴുതി ഇങ്ങനെ തരും, ഒരു ക്ലിനിക്കൽ സിനാരിയോ. അപ്പൊ അതിന്റെ ഉത്തരം നമ്മൾ എഴുതി കൊടുക്കണം. അപ്പൊ അങ്ങനെ പല രീതിയിലും, അതേസമയം ഒരു ഫ്രണ്ടിനെ പോലെ നമ്മുടെ തോളിൽ കൈയിട്ട് നടക്കുന്ന ആ ഒരു അനുഭവം ഒരിക്കലും മറക്കാൻ പറ്റില്ല. അതുപോലെ തന്നെ വളരെ നല്ല ക്ലിനിക്കൽ ക്ലൂസ്. ഇപ്പൊ സാറ് പറയുന്ന പല കാര്യങ്ങളും നമ്മൾ ഇപ്പോഴും അതേപോലെ പ്രാക്ടീസ് ചെയ്യുന്നുണ്ട്. ഇപ്പൊ ഒരു സ്മോൾ ഇൻഫന്റിനെയൊക്കെ ഒരു കാർഡിയോളജി എക്സാം സ്റ്റാർട്ട് ചെയ്യുമ്പോൾ ഫെമറൽ പൾസ് തുടങ്ങി അതാണ് ആദ്യം നോക്കുക, അല്ലെങ്കിൽ അത് മിസ് ചെയ്ത് പോകും എന്നൊക്കെയുള്ള പല കാര്യങ്ങളും സാറ് പഠിപ്പിച്ചത് പലതും ഞങ്ങൾ ഇപ്പോഴും അതുപോലെ തുടരുകയും വരുന്ന ജനറേഷനെ പഠിപ്പിക്കുകയും ചെയ്യുന്നുണ്ട്. അതുപോലെ സാറിന്റെ മകനെ ആലപ്പുഴ വെച്ച് പഠിപ്പിക്കാനുള്ള ഒരു ഭാഗ്യവും എനിക്ക് ഉണ്ടായിട്ടുണ്ട്. സാറിനെ പറ്റി പറയുമ്പോൾ, ഒഫീഷ്യലായിട്ട് പറയുമ്പോൾ, സാറ് സീനിയർ കൺസൾട്ടന്റ് പീഡിയാട്രിക് കാർഡിയോളജിസ്റ്റ്, കിംസ് ഹെൽത്ത് തിരുവനന്തപുരം, adjunct professor, Department of Cardiology, KMC Manipal, senior consultant pediatric cardiologist, St. Gregorius Medical Mission Hospital, Perumala, Kerala, Clinical Professor of Pediatric and Adolescent Cardiology, Child Development Center, Government Medical College, Thiruvananthapuram. Thiruvananthapuram Medical College Pediatric Cardiology Department established സാറാണ്. കേരളത്തിലും ഇന്ത്യയിലും ഒക്കെ തന്നെ വളരെ പ്രമുഖനായ പീഡിയാട്രിക് കാർഡിയോളജിസ്റ്റ് ആയ സുൽഫി സാറിനെ ഇന്നത്തെ ഈ ടോക്കിലേക്ക് IAP കോഴിക്കോടിന്റെ പേരിൽ സവിനയം സ്വാഗതം ചെയ്യുന്നു.
താങ്ക് യു. മോഹൻദാസ് പറഞ്ഞതുപോലെ നമ്മളൊരു ഫ്രണ്ട്ഷിപ്പ് ആയിരുന്നു അല്ലേ, അജിത്ത്, മോഹൻദാസ്, ഒരുപാട് പേര്. ഞാൻ ആ പോസ്റ്റ് DM കാലഘട്ടത്തിലെ നമ്മുടെ വളരെ ശക്തരായ രണ്ടുപേരായിരുന്നു അജിത്തും മോഹൻദാസും. അത് അവർ ഭയങ്കര വ്യക്തിമുദ്ര പതിപ്പിച്ചുകൊണ്ട് ബാക്കി ഇപ്പൊ ഓർമ്മിക്കുന്നില്ല അവരുടെ കൂടെ ഉണ്ടായിരുന്ന പോസ്റ്റ് ഗ്രാജുവേറ്റ്സ് ഒക്കെ ആരാണെന്ന് പോലും. എനിവേ, താങ്ക് യു മോഹൻദാസ് ഫോർ ദി വണ്ടർഫുൾ സ്നേഹത്തോടെയുള്ള. അതെനിക്കൊന്ന് ഈ മലബാറുകാർക്ക് ആ ഭാഗങ്ങളുള്ളവർക്കെ പറ്റുള്ളൂ എന്ന് തോന്നുന്നു. അങ്ങനെയൊക്കെ ഈവൻ ദോ ഐ ആം ഫ്രം ട്രിവാൻഡ്രം. ജയകുമാരെ, നമുക്ക് തുടങ്ങാമല്ലോ അല്ലേ? ആക്ച്വലി മോഹൻദാസ് ഒബിസിറ്റി എന്ന് പറഞ്ഞെങ്കിലും ഒബിസിറ്റിയെ പറ്റി ശക്തമായിട്ട് പറയാൻ കഴിയുക വലിയ മഹാത്മാര് ജയകുമാർ, റിയാസൊക്കെ ഉള്ളപ്പോഴേ ബേസിക്കലി അവർ ഡിസിഷൻ വാസ് ബേസിക്കലി ടു look at generally at the preventive cardiology in the young and adolescents. So we will see what can be done. കാണാമല്ലോ അല്ലേ?
ഇല്ല, സാറിന്റെ സ്ലൈഡ് വന്നിട്ടില്ല.
അത് ശരി.
സ്ക്രീൻ ഷെയർ കൊടുത്തില്ല സാർ.
ഞാൻ ഒന്നുകൂടെ തിരിച്ചു പോവാം. ശരി, സ്ക്രീൻ ഷെയർ അല്ലേ? സ്ക്രീൻ ഷെയർ ഇനിയാണ് വരുന്നത്. ഇപ്പോഴോ വിജയകുമാറെ?
വരുന്നുണ്ട് സാർ.
വരുന്നുണ്ട്
സാർ. സ്ലൈഡ് ഷോ. യെസ് സാർ, കറക്റ്റ് ആയിട്ട് വരുന്നു.
സ്ലൈഡ് ഷോ ആക്കി
സാർ. കോഴിക്കോടിന്റെ ചിത്രമാണല്ലോ.
കോഴിക്കോട് ചിത്രം തന്നെ കാണുന്നുണ്ട്. ഐ എം ഡിലൈറ്റഡ്, ആക്ച്വലി റിയലി ഡിലൈറ്റഡ് ടു ബി അറ്റ് വെർച്വലി അറ്റ്ലീസ്റ്റ് ഇൻ കോഴിക്കോട്. ഇനി ഞാൻ ഏപ്രിൽ വീണ്ടും വരുന്ന ഒരു ആഗ്രഹത്തിൽ ഇങ്ങനെ ഇരിക്കുകയാണ്. ഞാൻ കോഴിക്കോട് ഒരു എന്താ പറയാ, എത്രയോ കാലമായിട്ട് ഇങ്ങനെ വെരി നൈസ് ടു ബി ഇൻ കോഴിക്കോട്, അറ്റ്ലീസ്റ്റ് വെർച്വലി. So നമ്മുടെ theme of this tonight's discussion will be this, that is what John Milton said about childhood. The childhood shows the man as morning shows the day. So it is basically a morning of the day, which is childhood in terms of a human being. So the topic was lifestyle diseases in children and adolescents, and catch them young. That would be the motto of this particular title. So and this is what you call as a Doyens series. So when Mohandas said about this Doyens series, I was thinking about the 7 Ages of Man by William Shakespeare, when he started with an infant, then schoolboy, lover, soldier, justice, then a lean and slippered, finally a mere oblivion. That was the 7 stages of human being. So I told Mohandas, I suppose, I think there are 5 stages of medical speakers like me. MKC പറയുന്ന പോലെ നിലയ വിദ്വാൻമാരെന്ന് പറയും, സ്ഥിരമായിട്ട് സംസാരിക്കുന്നവർ. Stage 1 is, in the 90s, you are very young and upcoming, and later on you become more of a established faculty. You and other people also feel both feel that the speaker is okay. Stage 3, perhaps you reach the peak of this your career. And then you have the stage 4, when people call you Doyen, basically means that you are past the prime, but you respect that particular person, and the particular person feels that he is by definition of OED, Oxford Dictionary, you are the master of that subject. And then comes a downhill course where you have a living legend. So sometime between Doyen and living legend, somebody puts a ponada on your shoulders, then you are done. You better not to go on speaking. Anyway, I hope that I must be somewhere near that area, maybe stage 3 to stage 4, perhaps, hopefully. Anyway, so the prologue for this particular talk is that that a man was a hunter-gatherer till 12,000 years ago. And during that period, I think the basic problem for human beings, the diseases were zoonosis, as expected. Later on, man, 12,000 years ago, man settled near the river banks and started agriculture and settlements. So naturally, they settled because naturally they had infections. And agriculture, if there is a problem with the agriculture, failure, famine, you have nutritional problems. Later on in the 19th century onwards, you had the mechanical, industrial, and now the digital revolution. And that would paved the way for the what we call as a NCD or a lifestyle disease, of which the most important is a cardiovascular disease, according to general population, and also to me, because I'm primarily a pediatric cardiologist. Now, so we have actually, we know everywhere, you have either a communicable disease or a non-communicable disease, which is also called as basically a lifestyle disease because attributed primarily to the lifestyle. And we also know during our preventive medicine study, we know about various transition of epidemiology, that is death and disability caused by nutritional and infectious diseases slowly change to those caused by chronic diseases like degenerative diseases, which also is called lifestyle disease. And you can find that basically somewhere in this particular area, 1920s in the Western world, the infectious diseases moved away and chronic diseases started increasing and still possibly increasing up to the 1980s or 90s in the Western world. So these lifestyle diseases mostly are classified, as you know, into cardiovascular disease and other diseases, which includes cancer, respiratory problems, accidents, neuropsychiatric issues, diabetes, of course, a CVD risk factor, and rheumatic heart disease, particularly in India. And this great, what I thought was a great picture, is still from Seventh Seal, which was a movie made by Ingmar Bergman, and there were 7 of people were dancing. So I thought of 7 scenes like obesity, hypertension, smoking, diabetes, dyslipidemia, sedentary habit, and stress. These were the factors which led to this lifestyle disease. And this, again, among the 3 important areas is hypertension, which is around 20 to 40% in India. Diabetes, in urban, it is almost 10%, maybe more in Kerala also. And coronary artery disease as such is around 8 to 10%. So 1 out of 10 adults will have some sort of a coronary artery disease. And we also know that nowadays, I think it is at least 50-55% of death in India is now is due to NCD. And then among the NCDs, the largest share among the lifestyle diseases is a cardiovascular disease, which nowadays is around 35% of all NCD morbidity. So because of that factor and the fact that I am a pediatric cardiologist initially, so I would primarily stress on the cardiovascular diseases, and it's a major challenge globally. And we also have learned for the last 20 years or so that there has been a reversal of social gradient in the prevalence of CVD in India, which means that more and more so-called poor people get these diseases, which are generally thought to be a disease of the affluence. But there is definitely a reversal of gradient, which has been mentioned by K.S. Reddy, perhaps one of the biggest cardiac epidemiologists in the country. And second factor, which is particularly important in Kerala, is the age factor. That is, sometime back, I analyzed the acute coronary events in cardiac ICU in Medical College Trivandrum, which happens to be a snapshot of Kerala. And you find that 40% of them were less than 45 years, etc. No, basically, at least near half of them develop acute coronary event before they become 50, into their 50s. That is a very dangerous thing to have. And another thing is that India and China, what we are called as an emerging market economy compared to United States and Germany, which are already considered market economies, we have increasing burden over the last 20 years, whereas in many of the market economies like US, the burden of CVD is slowly coming down. So we have that problem also of affluence. And this again will tell you that among the top 10 causes of death in India, how do people die in India? The answer, the majority would be starting from coronary artery disease, stroke. So stroke and coronary artery disease, I think, are very crucial. and plus diabetes directly, kidney diseases, all these things would lead to death in India. And you find that among all these major causes of death compared to 2004 and then to 2010, 5 to 6 years later, the only disease which is definitely showing an increment is cardiovascular disease. Of course, you find a slight increase in suicides and motor vehicle accidents, logically. But again, the point is that the cardiovascular diseases happens to be edging more and more into the percentage of death in India. And I think all of us, practically all Malayalis, must be aware of this gentleman in a movie called Padayappa. So he was singing a song where it means, in translate into English, what you will find is that you cannot choose your father, you cannot choose your mother, you don't have that power. So you cannot even decide on your, pirapai, the birth and death, etc. So you don't have that kind of power. So they are called what you call as the unmodifiable or a non-modifiable factors in cardiovascular diseases, which means age, gender, and the family history. But perhaps a sliver of hope is that there are many modifiable risk factors in adult practice, which includes hypertension, diabetes, obesity, dyslipidemia, smoking, inactivity, and stress, the major factors which are modifiable factors. So we have to pin our hopes on those modifiable risk factors when we try to manage children and adolescents with these problems. Now, this is a biblical from the book of Revelation. It speaks about the end of the world where the Satan comes, and there are four horsemen of apocalypse. They're called the four horsemen of apocalypse, which basically imply doom to this particular world. So these four horsemen of apocalypse in terms of cardiology would be high blood pressure, obesity and metabolic syndrome, dyslipidemia, diabetes, and maybe a fifth horseman still going around in Kerala, in India, is smoking. So now look at Kerala. What about these factors, these horsemen in Kerala? Coronary artery disease, according to Ramankutty studies in Neyatigara, it's around 10%. High blood pressure, many of the studies from Kerala have shown approximately 30%. And diabetes may be at least less, around 10 to 15%. Obesity somewhere around 10%, as Mohandas was remarking. And dyslipidemia, we don't know exactly the burden in Kerala, and smoking somewhere around 20%, according to Dr. Rajmohan's study somewhere a little earlier. And another very interesting thing is, even in rural Kerala, these lifestyle diseases are very common. There's a study from Kerala showing diabetes in 15%, hypertension 1/3, hypercholesterolemia in 1/3 of the patients. Right? So these are very important dangerous marks of Kerala. Now we come to a very important study, which I think will have a definite relevance in our talk. That is the study called Effect of Potentially Modifiable Risk Factors Associated with Myocardial Infarction in 52 countries, what we call as an inter-heart study. And this study basically looked at only one question was asked. What are the potentially modifiable risk factors for acute myocardial infarction, heart attack, acute myocardial infarction? Only one question was asked in 52 countries, a huge number, a study versus a control population, and published around 2 decades ago by Salim Yusuf, who happens to be a Malayali. So these factors showed you that what we were thinking along were absolutely correct. That is, you have 9 factors, which includes an abnormal lipids, smoking, high blood pressure, diabetes, obesity, psychosocial factors including stress, then a lack of food rich in vegetables, lack of exercise, and slightly controversially, a moderate amount of alcohol protected people from acute myocardial infarction. Now, this again, more important point to be stressed is that this kind of study showed that it is applicable to both men and women, old and young, and all countries, irrespective of the country. It showed this effect. And then I think recently there is an article, 10 things to know about 10 cardiovascular disease risk factors in adult population. which again basically highlighted the basic study of in the heart study, all these factors. Of course, race, age, gender cannot be modifiable. And they also included kidney dysfunctions. Chronic kidney disease is also as an important cardiovascular risk factor in 2021 in adult population. Now we come to another subset called young adults. So this is another ambitious study started in 85, 82, 83, and coronary artery disease risk development in young adult study. Very famous study going on now. It's an ongoing study which prospectively try to analyze. And this is one of the articles on this. That's all. 18 to 30 years, young people, really young adults, a large number, and followed up mean period of 25 to 30 years or so. The point is that baseline data, just concentrate on the baseline data, which means the smoking is present in around 30%. That is age group, mean age is only 25 years, very young. Mean BMI was somewhere around 25. And hypertension, fortunately, was only 4%. And hypercholesterolemia was around 5%. And fasting blood sugar more than 126%, very small amount percentage in very young people. That is really talking about young people. Now compare this kind of a huge data with a very small data from Kerala, a rhythm study done in medical college Trivandrum. Actually, it was basically a dissertation by my son, Sajan. And they were looking at the cardiovascular disease risk factors in young professional. On your left-hand side is a medical college postgraduates. On your right-hand side is the techies from Karakutam. A significant number was selected, 25 to 40 years, which is probably the most productive years in terms of finance and other this thing. So this is the study showed. You see, around at least 1 out of 4 had hypertension. 1 out of 20 had frank diabetes, and around 10% of techies had obesity of obvious reasons, and they had a baseline value. See, baseline mean value was very high, relatively high in all these people, and the smoking was present again more in techies, and stress scores were also high. So basically, this highlights that in Kerala there may be all these risk factors may be operating very early in a young adult. So that is the situation in a real young adult, 25 to 40 years old. Now comes a question on our children and adolescents. That is perhaps the very important problem for a pediatrician as far as I am concerned. And if you look at generally the cardiovascular disease risk factors given in textbook, you find it is basically the same as that of an adult, except perhaps a role of nutrition. I think it's very important in pediatrics because, of course, the child and adolescent is a growing animal. So why do we need to start early, and how would be the major question nowadays to justify our interest in this particular preventive cardiology? And again, many of us will remember or at least be aware of this particular picture just taken during the Vietnam War when America bombed Vietnam with napalm bombs, and this is a naked girl running away from the Agent Orange bombs and all. And this was a war, a needless war where so many people died on both sides. And this girl who was running is now become a lady and is right now, ironically, lives in San Francisco, United States. Now, the point here is that during that war, as well as the Korean War, very young adults, not young adults, young people between 15 to 20 years, so many people recruited for this war. And then many of them died, and they did an autopsy on these young people, really kids, basically. It's all about kids. And they showed that coronary artery atherosclerosis was present surprisingly in those people. So that started many studies on childhood-onset adult cardiovascular diseases. So that is the beginning. The many good things in many aspects sometimes come from very bad things like war and all. But that doesn't justify war as we see now in 2022. Now, finally, these studies showed that the major cardiovascular disease risk factors start operating from childhood. dyslipidemia and atherosclerosis changes start in young adults and adolescents. And BMI, this is very important for us. BMI, blood pressure, and low HDL cholesterol at 15 years, 10th standard student, correlated with the coronary artery disease in adulthood. That is particularly relevant in Kerala, I suppose. And we have some data on hypertension in children. Very good data, actually. Around 5% of our children are hypertensive. Around 10% are either overweight or obese. We have right now, we don't have a real idea about what is happening to the dyslipidemia and insulin resistance in our children. Now, we are basically an emerging market economy. Brazil is also a sort of a middle income emerging market economy. There have been studies on school children, multiple cardiovascular risk factors recently. And it was a cross-sectional study on around 1,000 children from 12 to 17 years of age, both public school as well as private school, and which showed overall CVD risk factors were relatively high. See, 12% of them had a high blood pressure, 1/4 of them had obesity, and smoking very, very low, but alcohol was probably very high. Sedentary habits were there in almost 3/4 of these children, and family history of a cardiovascular disease was present in 1 out of 3 children. So many risk factors were operating in this particular Brazil study. So, and then we had in Preventive, you are aware of this, a small study on a government high school, a low profile government high school, which showed around 8 to 10% of them had high schoolers had high blood pressure. So that is an interesting situation here. So overall, the point is that cardiovascular disease risk factors in terms of autopsy, epidemiological data from various countries, small studies, all those things starts in adolescence and accelerates in adult to produce a cardiovascular disease in an adult population. So in that way, if you ask the question, will today's child be tomorrow's cardiac patient? The answer is possibly yes, because most of these risk factors will be there in a adolescent and may track into adult. Now, this is a very, very recent AHA statement from 21, cardiovascular risk reduction in high-risk pediatric patients, a scientific statement, which basically talks not only about the traditional risk factors, which we know, they also talk about medical conditions and congenital heart diseases, which also can lead on to increased cardiovascular disease risk. And this would include, these are the traditional factors, which we all are aware, but we should also be aware of chronic kidney disease, chronic inflammatory disease, childhood cancer treatment, and Kawasaki disease, post-transplant situations, congenital heart disease and coronary anomalies. They are slowly emerging as some of the medical conditions which could lead to early cardiovascular disease, and they would start basically from childhood and adolescence. So the question is, if these factors start operating, traditional and non-traditional cardiovascular disease risk factors in childhood start operating in childhood, can the prevention and treatment of these risk factors reduce adult cardiovascular disease? Will they benefit? The answer logically must be yes. So that means the preventive cardiology in the young, or what we call as the lifestyle disease management in the young population, we are actually exploring new frontiers in preventive cardiology. See, for example, when we speak about preventive cardiology in adult cardiology perspective, usually we think of a secondary prevention. Once you have a heart attack, you start him on statin and aspirin. Sometimes you have diabetes, controlled diabetes, hypertension is controlled in an adult, which is called primary prevention. But you must have what we call as a primordial prevention, extending backwards to even a lifetime prevention that would start from adolescent population. So I will try to give you an overview of these major cardiovascular risk factors, what we call as factors leading to lifestyle diseases in the young. And one would be high blood pressure, and that is hypertension. And why is it important? Because the adult population, at least 50% of stroke, 25% of heart attacks are due to hypertension, and you have also involvement of the eyes, the peripheral vessels, and the kidney due to hypertension. Now, why pediatric high blood pressure is important? That is because adult hypertension has definite antecedents in childhood, and very, very importantly, childhood hypertension can track to adult and cause cardiovascular disease, very clearly proven. So this is, of course, the tracking phenomenon. That means adolescents who have high centiles, even if they are considered normal, continue to have high centiles, and they are likely to develop hypertension later in young adult, provided you get some additional toxic influence somewhere during post-adolescence period, like obesity, sedentary habit, smoking, stress situation. All those things can make them hypertensive as a young adult. And this hypertension in an adult is only an arbitrary answer because it produces cardiovascular diseases. So when the risk is double that of a control population, that blood pressure value in an adult is called hypertension. So that would be 140 to 90. That is a rationale for saying 140-90, above that is hypertension. But in pediatrics, as usual, we have the centiles up to 13 years and later up to 18 years. Normal, as you know very well, is less than 90th centile. The pre-hypertension term is removed and has been replaced by elevated blood pressure between 90th centile and 90th centile. And above that would be either a stage 1 hypertension or a stage 2 hypertension. And in India, we find that over the years, for the last 60 years, it has been increasing, even up to 40% in some part of our country. And there has been a big systematic review in 2014, huge study looking at urban, rural, north, east, west, south, everywhere, and approximately it's around 30% incidence, prevalence of hypertension in adults. And along with the increasing in prevalence of adult hypertension, pediatric hypertension also has been increasing over the last 20 years or so. And most of us will be aware of this Dr. Manuraj's study from Cochin showing prevalence to be somewhere around 4 to 5% in school children, ranging from 5 years to 16 years. You know, real school children, not adolescents alone, but school children. And naturally, why should we treat high blood pressure? Because it would definitely reduce cardiovascular mortality and morbidity. And of course, if there are symptoms, it would abolish or reduce. And a very practical thing in adult hypertension is that if you reduce 2 millimeters of mercury systolic BP, and it will cause a 10% reduction of death by stroke, 7% reduction of death by acute coronary event. This applies to adult population. But how do you treat this high blood pressure in an adolescent? Would be a lifestyle modification and sometimes drugs. And the lifestyle modification primarily is that of sodium and dietary supplementation of potassium, weight reduction, exercise. The triumvirate would be diet, sodium, weight reduction, and exercise, and followed by a stress management, vegetarian diet, increasing fiber intake, etc. And you must also be aware that the Dravidians have a very high salt sensitivity. We are very sensitive to salt. So even an absolute reduction of salt will be transformed blood pressure into a lower value. And I hope that all of us recognize the gentleman who is making salt from the sea. So another very practical point. This applies to an adolescent. The previous one was adult. This applies to an adolescent. That means if you reduce 1 kilogram weight from an adolescent, it will reduce blood pressure, systolic blood pressure, at least by 2 millimeters, diastolic by at least 1 to 2 millimeters of mercury. And there are many other lifestyle modifications like a DASH diet, physical activity that would definitely cause a reduction in blood pressure. So we can convert a stage 1 into a late what you call as elevated BP, and elevated BP can come down to normal BP by a lifestyle modification. And some cases we may have to use drugs also for managing hypertension. This is a very obvious, very common slide, but this is highlighted by perhaps the most important magazine in the world, looking at every aspects of this the current affairs in the world. And we also know the adult definition of obesity, and we also are aware of how to measure, assess obesity based on the BMI chart, which we are very fond of. And India has around 10 to 20% of population has got obesity, and this obesity has been increasing over the last so many years all over the world as well as in India. And again, just like cardiovascular and other risk factors, little or no social difference in many part of the country, and less developed countries are also affected by this. So in India, from an endemic, now we have an epidemic, hopefully going into an endemic in COVID, but this has been an endemic which has gone into an epidemic in Kerala, especially, as Vijaykumar was highlighting. And again also highlighted by Manuraj, saying that around 6% of young children, 5 to 16 years, had overweight or obesity. And we are aware of these factors: parental obesity, sedentary behavior. 2 and 3, I think, are particularly prominent during these COVID days. And birth weight also is very important in both ways. We will come to that later. And we have, this is a roadmap for obesity. And why should this obesity be arrested early? Because it has a long-term, a negative impact of early obesity. This is the fat boy in Charles Dickens' novel. Tracking of childhood obesity to adulthood, like hypertension, and morbidity is linked to obesity, and it is relatively sensitive to treatment. Those people who are very committed in managing obesity, like Vijaykumar or Riyas or many other people, Dr. Shija in my hospital, I think they know that it is definitely sensitive to treatment. And in 2017, and the US had come with a recommendation for screening for obesity in children and adolescents, because it's very easy. And once you screen, you divide them into 2 groups, overweight and obesity, and offer them a comprehensive intensive intervention. And this would be basically what you call as a clinical approach, take care of only the obese and overweight in a clinic, as we do right now. And also to reduce a little risk in most people, like the population approach, which may be a lifestyle changes, which would be a long enduring vision of management of obesity. And this, I will not go into this. This is basically about the active weight goals, which I will not say. And we'll quickly go to diabetes, which we all know that India happens to be a diabetic capital. And we, to some extent with pride, we say Kerala is a diabetic capital of India. And we know there's a type 2 diabetes is increasingly common in Kerala. And the prevalence of diabetes in an adult may be as high as 15% in urban population like Trivandrum, against an Indian average of around 6% population. And we have another problem, that is like obesity, hypertension. They're all associated with diabetes in Kerala population, along with the insulin resistance with obesity. I think have this metabolic, infamous metabolic syndrome. And the diabetes in the young, basically, it's all about weight management, exercise, glycemic control, and additional risk factor, if there are any, like hypertension, to be managed along with obesity. Now we come to another very, I think that is, this is the primary, what you call as the common road to perdition, that is atherosclerosis. Everything comes here, and then it channels into cardiovascular disease, death, and morbidity. And we know that from the various studies in Vietnam, Korea, Bogalusa study, the plaques, which are sine qua non of atherosclerosis, starts as early as 15 years of age. And we know what is meant by a dyslipidemia. And why should you do lipids, or why should you do lipids in children and adolescents? Is the question, because the atherosclerosis, as we know, starts in adolescence. And we should know the values also, which I think I'll skip. So the point is that suppose you identify dyslipidemia in a young person, will most likely we can translate into lower lipid values if you reduce the lipid values. And these lowered lipid values in such adults may lead to reduction of cardiovascular disease. But it's not proven, but we hope so. And we must naturally will have, generally we go right now for a targeted approach, screening, look at the high risk people like parent, grandparent, aunt and uncle, sibling with the various features, dyslipidemia, all those things. But there is recently, not so recently, 5 or 6 years back, there were again very aggressive mode of management screening for dyslipidemia also. And in many of the states in United States, they are offering universal screening to all children between 9 to 11 years. But this is controversial even in US. And can we adopt this? Less likely, because it's difficult to achieve, and of course, less of priority, and may enhance the parental anxiety also, especially in Kerala. When you are managing, you are aware of diet, exercise, drugs, and a combination. And drugs, of course, to be very careful. Boys only after 10 years, girls only after SMR2, or minimum age would be generally around 8 years, according to American Academy of Pediatrics, which happen to be a little more aggressive than the American Heart Association, very interestingly. And we have other factors: exercise, smoking, alcohol. And I think this, again, at least many of us know this painting by Van Gogh. And he drew this picture of a smoking skull when he was 18. He was a student of painting. And this is a very important thing. In Kerala, we have one of the higher percentage of smoking in teenage population, based on the Cochin study. Again, many of our stalwarts in IAP had done this particular study. The point I want to make is that at 15 years in Kerala, only 2% of boys smoked, according to a study in Trivandrum. But by 20 years, 15%. So the transition occurs somewhere between 15 to 20 years. That is the period which we should concentrate on reducing. And along with that, you should also look at stress reduction. Substance abuse, in a simple government high school in Trivandrum, where we studied, there was a significant percentage of substance abuse also. So many of these risk factors are tracking. So they basically, if they track, which means that it's better that you intervene at the adolescent period. Then there are, of course, novel risk factors like Kawasaki disease and Barker hypothesis. And I will straight away go into that Barker hypothesis quickly. That is the fetal origins of adult cardiovascular disease. This is Barker hypothesis. What he did was that he showed that low birth weight in infants born between 1915 to 1920 in northern part of UK had a higher risk of hypertension, dyslipidemia, and diabetes, obesity, and acute coronary events in adulthood. So basically, the hypothesis says low birth weights, reduced fetal growth will lead to cardiovascular disease, morbidity, and mortality. And if you look at this graph, this thick line, you find that you can compare birth weight versus relative frequency of deaths due to cardiovascular disease. When the birth weight is very low, it is very, very high also, you have a problem. And if it is very low also, you have a problem increasing. So this is what is meant by the Barker hypothesis. And there have been questions on this fetal origin. For example, is it operating elsewhere? There are many studies all over the world showing this hypothesis exists, including India. In a Mysore study, they showed that if you have CAD later in life of a normal birth weight, only 3%, whereas a low birth weight population had a very high percentage, almost 10% of them had a cardiac disease. And of course, we know in 22, we have witnessing a potential beginning of a third world war. And in 1939, we had the Second World War. And that made two very major man-made disasters, a Dutch famine and Leningrad siege, both by the Germans. And this has shown epidemiological proof that Barker hypothesis may be existing. And perhaps the most important is the Dutch famine, what we call as the Dutch hunger study, which happened in Holland, where Germans blockaded the many bridges, including this famous bridge Arnhem, and blocked entry of food into a village. And this blockade caused a food embargo, very harsh winter at that time, naval trade blockade, delay in liberation. And the Allies concentrated more on the liberation of mainland Europe, like France, and rather than Netherlands. So there was a problem where a very severe malnutrition in adult population, including women, pregnant women. And this study, this was done in this was happened in 1944-45. And what happened was they looked at the birth weight of these babies. who were not exposed, which means the baby was born either before the war or completely conceived and delivered after the war. And those babies who were exposed to severe malnutrition, maternal malnutrition in the early gestation period, and they had a very high prevalence of cardiovascular disease when they became adult population. So that again confirmed that Barker hypothesis exists. So this showed that the relationship between the famine and the CAD is independent of birth weight, and adult who had CAD had a definite lower birth weight. So which means that birth weight is basically depends on the intrauterine environment. So if you have a negative intrauterine environment, which can lead to low birth weight, which can lead to cardiovascular disease. There was another study, again, Leningrad study, which did not show a much influence on this low birth weight and future CAD, and possibly because people thought that the Dutch became very, very affluent after the Second World War. So there was a mismatch between prenatal malnutrition and postnatal gain in weight, whereas in Leningrad, they continue to have significant poverty. So there may be the reason why there was well-matched prenatal as well as the postnatal. And the point is, basically there is a mismatch, and pregnant women are most vulnerable. And because pregnant women are most vulnerable, babies too are vulnerable. So we have a saying that you are what you eat, many of the nutrition speeches start with this, you are what you eat. But this Dutch famine study showed that you are what your mothers ate. And this was proved by the Dutch hunger winter study in 1944. So talking about the women, the mother, and looking at Amartya Sen's concept on 4 kinds of gender inequality, that is the undernourishment of girls over boys, undernourishment of mothers, prevalence of low birth weight, high incidence of CVD, and less management of CVD in the female population as a problem. And we know that there is a relationship between child survival and gender equality. And now we also think that there is a relationship between gender inequality and adult onset cardiovascular disease because of we are not doing enough to protect the adolescent girl. So what he said was, given the uniquely critical role of women in the reproductive process, it would be hard to imagine that the deprivation to which women are subjected would not have some adverse impact on the lives of all men as well as women, adults as well as children. So we basically, it's a low birth weight, leads to an undernourished girl, undernourished mother, and again, it perpetuates a cycle. So what we have is a central point is or a beginning point is actually a malnourished adolescent girl. So that is why this preventive cardiology or preventive lifestyle diseases again should focus on an adolescent, especially an adolescent girl. And this is a link between all these factors. And we also know that poverty will produce either excess infant death or survivors, and the survivors will what you call is programmed, and then they can have a postnatal increasing burden of cardiovascular disease. So coming back to our same AHA statement, they say that you have to assess these CVD risk factors, all those factors, and then you can divide it into high risk, moderate risk, and at risk groups and manage accordingly. So risk stratification, assess all CVD risk factors, and therapeutic lifestyle changes, and sometimes, if needed, drug therapy. And of course, about the universal screening, the possible candidates, of course, will be blood pressure, obesity, and perhaps lipids in the future. And also, I think basically we should look at the rheumatic fever, rheumatic heart disease in India. So, but the point is that universal screening, when you propose, it needs a high burden of proof. So basically, these are the possible screening in adolescents, like weight, height will give you the BMI, blood pressure, and the questionnaire on sedentary behavior, stress, smoking, substance abuse, and family history will be useful. Lipids and blood sugar probably needs an invasive, that is, you have to take blood sample, and there may be logistic issues. So this is what has been done, a part of a government program, and also a part of the Presidential Action Program from IAP. This is non-communicable disease and adolescent screening and intervention. Higher secondary school students, 11th standard students in Kerala, which has started off with the great success. They started off So it will continue to be successful. So in conclusion, I think basically, as Hamlet says in the drama, readiness is all for all pediatricians, people looking at children's health nowadays. I think previously we used to be like a roadside garages, treating diseases only. But I think now we must not only sell disease, we must also sell health to our parents and children with the suspect cardiovascular risk factors. So thank you very much. My real gratitude, genuine gratitude to IAP Kozhikode and all my friends everywhere. Everywhere in IAP as well as in particularly in Kozhikode. Thank you. I think I've taken a little more 40 minutes. I suppose it is pardonable from an old friend, Le Mohandas.
Sir.
Thank you.
Thank you, Sulfi sir. Now the topic is open for discussion.
Stop sharing, alle?
Sir.
Dr. Narayanan, our immediate past president.
Narayanan, another of my favorites.
Yes, sir. Yes, sir. I am even again listening to my teacher, his presentation. It is just like watching a movie with a lot of images and a lot of messages, and of course, and with a lot of data also, both from the international scenario and the Kerala scenario. So, one clarification or one needed is regarding the treatment with statin. What is your experience?
Okay.
About 10 years, which is the preferred statin and what all things we should look for, or how frequently you get adverse events?
Okay. I think statins, I think the most important thing about the statin, all pediatrics should be aware, is that two things. The age ceiling is there, and very rigid threshold. Threshold should be very high in starting a statin in adolescent population children. So, I told you basically American Heart Association is somewhat more conservative than American Academy of Pediatrics, because the cutoff for AHA is 10 years, whereas AAP is 8 years. So there is some difference. That is a differential point. A second point, I think, for example, we have been giving statins for nephrotic syndrome in very young children. You find that below 8 years, I think it is practically relatively contraindicated. You should be aware of that. That is a very important point. Another point is that, so all over the world, let me come to my experience, which is limited, but all over the world, the major area where statins are being regularly used in children or adolescents in familial homozygous hypercholesterolemia, not even in the familial multifactorial polygenic kind of heterozygous. So all over the world, there are limited indications, limited experience on statins. And we have also very limited experience in what we call as an adolescent with very high cholesterol. Because, for example, in an adult of 140 milligram of LDL would warrant a statin, whereas 190 would be the cutoff, I suppose, in an adolescent when you start. So very, very high threshold. That is one which you should remember. And the second part is statins. I think there is no difference. And it's a class effect. So basically, you can use atorvastatin, rosuvastatin. Only thing is 10 milligram, of rosuvastatin is almost equal to 20 to 30 milligram of atorvastatin. So you should use it accordingly. So usually they say rosuvastatin 5 milligram, atorvastatin 10 milligram to be started with the baseline liver function and all. And whoever I've been given, I have some experience in young adults, like being a cardiologist. Young adults on statins, they have almost none of them have significant problems. But occasionally you have a statin myopathy, once in a while a death, but that will get highlighted. Otherwise, I think it's a very safe drug. Then there were people who were again saying that instead of statin, we can use ezetimibe, which is not a statin, which has less chance of myopathy and the liver problem. But there has been no study showing, not only in children, but also in adults, showing that the acetamabile reduction of cholesterol will translate into reduction of CVD. That is the problem. So only statin has been shown to genuinely reduce the CVD. So if at all we use drugs in pediatrics, I think we should be using statins, but very high threshold for starting statin.
Yeah, thank you, sir.
We have our secretary, Dr. Johnny Sebastian.
Johnny, oh, I see.
What is this, sir?
Sir. Yeah, respected Chair Mohandas sir, and all seniors, teachers, and dear friends. That was an excellent master class, power packed, sir. Thank you so much. Thank you so much for the excellent presentation. Very informative. In fact, we can take a class after hearing your class.
Thank you.
Thank you, sir.
So when Johnny says this particular sentence, I feel very, humbled, because Oscar Wilde ഒരിക്കൽ പറഞ്ഞിട്ടുണ്ട് ബ്രിട്ടീഷ് എഡ്യൂക്കേഷനെ പറ്റിയാണ് പുള്ളി പറഞ്ഞത്. He said that anybody who is incapable of learning has started teaching. So whenever I start teaching people like Mohandas, now he's professor and HOD. So that's very nice. I mean, we always think of this Oscar Wilde's statement. So I'm very cautious nowadays.
Sir, we have Dr. Basavaraja.
Yes, my friend. Yeah.
Yeah, thank you very much.
Yes, join. Hello.
Really, I missed you. You are so free.
You are in the car.
No, just now I landed in the Nagpur, sir.
Oh, I see.
Yeah.
We were just discussing that traveling by multiple flights and all. Okay.
No, actually flight was for tomorrow, but it is rescheduled, sir. That was the reason I missed your.
Okay, that's okay.
Thank you very much, Ajay. Mohandas Nair, sir. Thank you, Vijay Kumar, sir. Narayan, sir. Nisha. Thank you all.
Hello.
Thank you, sir.
Thank you.
Thank you, sir.
Johnny, thank you, Johnny.
Yeah, thank you, sir.
Thank you.
Dr. Ravi, sir. Ravi, sir, is there NNF? Hari Kumar.
I am here.
Sir.
Yes. As usual, it was ഒരു വെടിക്കെട്ട് എന്നൊക്കെ പറയില്ലേ, നമ്മുടെ തൃശ്ശൂർ പൂരത്തിന്റെ വെടിക്കെട്ടൊക്കെ കാണുന്ന ഒരു കാർഡിയോളജിയുടെ ഒരു ശരിക്കും നമ്മള് ഒരു അൺഡിവൈഡഡ് അറ്റൻഷൻ പിടിച്ചു പറ്റുന്ന ഒരു ടോക്കാണ് എപ്പോഴും നമ്മുടെ സുൽഫി സാറിന്റെ. അത് നമ്മൾ ഒരിക്കലും മിസ് ചെയ്യാറുമില്ല. മിസ് ചെയ്താൽ അത് ഒരു ലോസ് തന്നെയാണ്. അപ്പൊ ശരിക്കും ഒരു ഭയങ്കര, അതായത് ഇന്നത്തെ ഈ വേൾഡ് ഒബേസിറ്റി ഡേക്ക് ഏറ്റവും റിലവന്റ് ആയിട്ടുള്ള ഒരു ടോക്ക് ഐ തിങ്ക് IAP Calicut has organized, and he has got the best available speaker, and it has been a really enlightening session. Thank you very much.
Thank you, Ravi.
വെടിക്കെട്ടിന് നന്ദി.
അയ്യോ, പറയല്ല, ഇങ്ങനെയൊക്കെ പറഞ്ഞു കഴിഞ്ഞാൽ ചിലപ്പോ ഞാൻ ബിലീവ് ചെയ്തേക്കും. ദാറ്റ് ഈസ് വെരി ഡേഞ്ചറസ് അല്ലേ നാരായണൻ?
അതെ സാർ, പൊന്നാട ഇടരുതല്ലേ പറഞ്ഞിരിക്കാൻ സാറേ?
ഇടാൻ ഇട്ട് കഴിഞ്ഞാൽ പോയി.
സാർ എല്ലാവരും ശ്രദ്ധിക്കുക, IAP കേരള NNF എല്ലാം ശ്രദ്ധിക്കുക. സാറിന് പൊന്നാട ഇടരുത്. അടുത്ത
പൊന്നാട ഇടാനുള്ള പ്രായമൊന്നും ആയിട്ടില്ല.
അതാണ്
അതൊക്കെ കുറെ കഴിഞ്ഞ
Dr. Jose.
Sulfik sir. Good evening, sir.
Hello, Jose. ജോസിന് പകരം ഫ്ലവേഴ്സ് ആണ് അല്ലേ?
Thank you, sir, for excellent talk. One doubt, sir. Statin start ചെയ്യുന്നത് സാറേ, സ്റ്റാറ്റിൻ നമ്മളിപ്പോ സ്റ്റാർട്ട് ചെയ്യണമെന്നുണ്ടെങ്കിൽ ഡിസ്ലിപ്പിഡിമിയ ഉണ്ടെങ്കിൽ മാത്രം സ്റ്റാർട്ട് ചെയ്താൽ മതി, അല്ലെങ്കിൽ പ്രൊഫൈലാറ്റിക് ആയിട്ട് സ്റ്റാർട്ട് ചെയ്യാവോ?
No, absolutely not. Because even dyslipidemia in an adolescent, there is a high threshold. You cannot the same cholesterol which usually warrants a statin in an adult does not apply to a child. See, for example, even if a young person, 24-year-old, 25-year-old person with a high cholesterol, we must again think twice or try starting on statin, because it is going to be a lifetime affair. So we have to be very careful in starting statin.
Ajit, Dr. Ajit Kumar is here.
Thank you, sir. Thank you, sir.
Ajit, hello,
Yeah,
Ajit.
sir. Good evening. Sir, good evening.
Good evening.
I'm really happy to see you, sir.
Mohandas was describing younger days.
Actually, sir was actually, it's always a pleasure to see and hear Sulfisal's talk. And ഞാൻ കുറച്ച് ലേറ്റ് ആയി, ഞാൻ ഫ്രണ്ടിന്റെ വീട്ടിലാണ്. But still, I could follow everything what sir was saying. From 1996 onwards, sir was talking about because that's the time when we had contact with Sulfisar when he completed his DM 1996 95 sir out vannathu. And from he was talking and we were discussing the markers and how it affects the from fetal to adult life. And sir, one important thing that has come out now recently is that the hypothermia that in newborn babies who are asphyxiated, especially from the low and middle income group countries, that it's not very effective when you compare with those children from Europe and other US and all these things, because the genetic profile of children in low and middle income group countries have changed, so that hypothermia is not, maybe because the long-term malnutrition, as you have said, sir, fetal programming has affected gene expression as well. That's what maybe that's the reason. Maybe it will take some couple of years for gene expression to come down and all these things. So one question can sir is, we have a child now in the ward with very high triglycerides. So this child is around 2 years, and child has huge hepatomegaly with, and we are thinking of glycogen storage disease. So whether to treat that hypertriglyceridemia in a glycogen storage disease, suspected glycogen storage.
What is the triglyceride value?
Value is around more than 300, 400 like
300. See, the point is, when you treat a triglyceride in a child, you should know the aim. It is not to reduce the CVD event, because high triglycerides may not produce directly lead on to a premature CAD. It is basically to prevent the other problems like pancreatic issues, all those acute problems, not CAD prevention. So with that in mind only, you should apply these drugs like fibric acid derivatives in this patient. Because if it is a part of a glycogen disease or a storage disease, this 300, 400, 300, 350 values, you have to be very sure, you have to be a little reluctant to start fibric acid derivative.
Okay. And omega-3, is it useful in children, sir, like just unlike in adults? Like
I think omega-3 in hypercholesterolemia in adolescents, I think it produces 3 to 5% reduction of total cholesterol, LDL cholesterol.
No, can it be used in younger children?
It can be used in younger children also. Yeah, that would be, see, two drugs which could be used in younger children as compared to a statin would be ezetimibe and this one, this omega. But the point is that the benefit of these two drugs is to the tune of 3 to 5% reduction.
Okay.
And we have a very high threshold of cholesterol, so it will reduce it now 190 to 175 or something like that. That's all.
Okay. So thank you very much, sir. It is always a pleasure to hear you.
See you. Always a pleasure.
See you.
Okay. Jagakrishnan is there.
Jagishnu was one of, again, see, I have so many friends and colleagues and erstwhile students. That's
Yes,
very nice.
students.
Actually, അതാണ് ഇന്നത്തെ സന്തോഷത്തിന്റെ ഏറ്റവും പ്രധാനപ്പെട്ട കാര്യം എന്ന് എനിക്ക് തോന്നുന്നു. I mean, of course, we have to be aware of.
Calicut എന്നാണല്ലേ?
അതാ exactly correct. വേറെ ആരും കേൾക്കണ്ട.
ജയകൃഷ്ണൻ ഉണ്ട് അവിടെ.
Thank you, sir. That was excellent.
ഞാൻ കണ്ടിരുന്നു.
നല്ല എക്സ്പീരിയൻസ് സാറിന് പിന്നെയും കാണാൻ പറ്റിയതിൽ വലിയ സന്തോഷം.
Exactly, precisely.
We have Harikumar, Nisha, Sunu.
Sir, it was an excellent presentation, and it was a very happy moment to be present in the session. Sir, I am just from starting from where Dr. Narayan sir had stopped. So sometimes we feel like, when you fail your counseling and all, again diet restriction and all. When an obese child enters your OP, you should give something to him other than your
advice.
usual talk. അഡ്വൈസ് നീ വന്നോട്ട് ഇതൊന്നും പോരാ, നീ കൊടുത്ത ഇതൊന്നും പോരാ, ഇതൊരു ശരിയാവുന്നില്ല, നിന്റെ ഫുഡ് അങ്ങോട്ട് ശരിയാവും. പറഞ്ഞു ഞാൻ 1 കിലോയോ കുറഞ്ഞുള്ളൂ ഡോക്ടറെ, ഞാൻ ഡോക്ടർ പറഞ്ഞ പോലെയൊക്കെ ചെയ്തു. But one more thing, Vijaykumar sir is there. So is that metformin can we use in obesity? I know there are certain restrictions and age. This thing. No, is metformin has any role in treatment of obesity?
Vijaykumar.
Sir, ഈ ക്വസ്റ്റ്യൻ സാറ് ഞാൻ പറയുന്നത് മെറ്റ്ഫോമിന്റെ ഒരു ഡെഫിനിറ്റ് റോൾ വെൻ ദ ചൈൽഡ് ഇസ് ഹാവിങ് എൻ ഇംപയർഡ് ഗ്ലൂക്കോസ് ടോളറൻസ് ആൻഡ് ഓർ ഒരു പ്രീ ഡയബറ്റിക് സ്റ്റേറ്റിലാവുക, അല്ലെങ്കിൽ വെൻ ദ HbA1c is above 6.5, that is the only indication for metformin എന്നാണ് ഞാൻ സാധാരണ പറയുന്നത് സർ. That is
always because ഒരു സെന്റൻസ് ഉള്ളത് ഒരു ടെക്സ്റ്റ് ബുക്കിൽ എനിക്ക് ഭയങ്കര ഇഷ്ടപ്പെട്ട ഒരു സെന്റൻസ്, don't jump start metformin.
Yes.
So be very, very careful. Drugs,
that is a very dangerous drug also sometimes. Sometimes if the child is having a definite pre-diabetic state and if HbA1c is above 6.5, then you can start. Otherwise, sir's opinion is, sir?
I think I agree fully with you. I think I'm basically very conservative about metformin use in children and adolescents. And I think even this weight reducing agents, no?
Yes, sir.
And that's also a little tricky, that orlistat, all those things. You have to be very, very careful. I think whatever said and done in adolescents in preventive, this cardiology or whatever, I think minimal use of drugs, I think, very important.
സർ, ഒരു ഡൗട്ട്, ഇപ്പൊ ഡയറ്റിൽ നമ്മൾ റെസ്ട്രിക്ട് ചെയ്യേണ്ടത് ഹൈ ലൈപ്പിഡ് ഡയറ്റ് ആണോ ഹൈ കാർബോഹൈഡ്രേറ്റ്
ആണോ എന്നുള്ളതാണ് ഇപ്പോഴത്തെ ഒരു അല്ലേ. എനിക്കൊന്ന് ഈ DGA ഗൈഡ് ലൈൻസ് US വന്നതിന് ശേഷമാണ് കോൺസെൻട്രേറ്റിംഗ് മോർ ഓൺ ദ റിഡക്ഷൻ ഓഫ് കാർബോഹൈഡ്രേറ്റ്സ് ആൻഡ് not much harm in what you used to call as fatty food and all. So വിജയകുമാർ, അതിന്റെ എങ്ങനെയാണ് ഡയറ്റിന്റെ ഒരു ആസ്പെക്ട് അല്ലേ നമ്മുടെ പിള്ളേർക്ക് എങ്ങനെയാണ്? ഹൗ ക്യാൻ വി ട്രാൻസ്ലേറ്റ് ദിസ് അഡൾട്ട് പ്രാക്ടീസ് ഗൈഡ് ലൈൻസ് ഇൻടു പീഡിയാട്രിക് ഏജ് ഗ്രൂപ്പ്?
I think if you take excess carbohydrate, that will be finally converted to fat and that will get stored. Whether you take more carbohydrate or more fat, both are dangerous. അപ്പൊ നമ്മുടെ കുട്ടികൾ അധികം കാർബോഹൈഡ്രേറ്റ് അധികം കഴിക്കുക. ഈ ഒബീസ് കുട്ടികൾ ചോറ് ഭയങ്കരമായിട്ട് കഴിക്കുന്നത്, കാർബോഹൈഡ്രേറ്റ് ആണ് അധികം കഴിക്കുന്നത് അവർ.
There are many children. Today I had seen one 11-year-old girl who was basically obese, and Dr. Shija was looking after the child, and he had a triglyceride of 320. So this particular day, I think I had a discussion with Shija, and I was telling her that we should be reluctant to start fabric acid now. I think we should look at the insulin resistance and other things before starting an treatment for an isolated triglyceride, But again, as Vijaykumar was saying, she's very fond of rice. Rice ആണ് കുട്ടിയുടെ.
അരിയാഹാരം കഴിക്കുന്ന മലയാളി.
അതെ, നമ്മുടെ അച്യുതാനന്ദന്റെ ഡയലോഗ് ആണല്ലേ.
അരിയാഹാരം ഭയങ്കര ഇഷ്ടമായിരിക്കും ഒബീസ് കുട്ടികൾക്ക് അധികം.
Even എൻ്റെ grandchild has slowly transformed from normal to overweight because of this COVID.
Yes, sir. Yes, sir.
Ajayan, എന്ത് പറയും?
Hi, sir.
Thank you. So thank you for inviting. I mean, virtually inviting. Again, we will anyway meet in April, no? അല്ലെ മോഹൻദാസ്? മോഹൻദാസ് അവിടെ കാണുമായിരിക്കും വിചാരിക്കുന്നു. അജിത്ത്
ഞങ്ങളൊക്കെ ഉണ്ടാവും സർ. അജിത്ത് എവിടെ ഉണ്ട്?
അതും
വെർച്വൽ അല്ലേ? അതും വെർച്വൽ ആണല്ലോ അല്ലേ?
എങ്ങനെ?
അതും
വെർച്വൽ ആണ്. ഓ ശരിയാ, അതും വെർച്വൽ ആണ്. പക്ഷെ നമ്മള് കാർഡിയോളജിക്കൽ സൊസൈറ്റിക്കാര് മെയില് തൃശ്ശൂരില് നമ്മൾ വിചാരിച്ചിരിക്കുന്നത് ഫിസിക്കൽ ആയിരിക്കും എന്നാണ് വിചാരിച്ചു പോണത്. എനിക്ക് ആയിട്ടുണ്ടോ
ഫിസിക്കൽ ആവാം
അല്ലേ? പതുക്കെ ആവാം. നാളെ തന്നെ ഞാൻ ആദ്യമായിട്ട് ആഫ്റ്റർ കോവിഡ് നാളെ ബാറ്റ്മാൻ കാണാൻ ബുക്ക് ചെയ്തിരിക്കുകയാണ്. നാളെയാണ് തുടങ്ങുന്നത്. 2 years I have been away from movie theaters. And Mohandas and Ajit knows, alle, the pain.
Sir, on behalf of IAP Kozhikode, sincere thanks to Sulfikar sir for that wonderful class on lifestyle changes which we need to implement. And it was excellent presentation with lot of stories in between to keep us occupied. Thank you, sir. And also would like to thank Baswaraj sir, who in spite of his busy schedule could join us for the meeting. And also thank President of IAP Kerala Vijaykumar sir, President of IAP Kozhikode Mohandas sir, and NF President Ravi sir, past President of IAP Kerala Narayana sir, and all of the seniors who has joined for the presentation. Thank you everyone. So we will meet again in the next meeting. Thank you all.
Thank you.
Thank you very much.
Thank you, sir.
Good night.
Good night,
sir.
Mohandas sir, thank you. We missed you. Sometime next time.
Yeah. Okay.
Thank you, sir.
Because sir, thank you.
Thank you, Johnny. Thank you, Narayan sir.
Yeah, thank you. Good night.